Good morning. It's nice to see you folks, even if it is through a computer screen. Today we are going to discuss complex medical history, patient assessment and evaluation, therapeutic management of common oral lesions, significance to dentistry of medicine and drug interactions, and drugs used in complementary and alternative medicine and their significance in dentistry. So, medical history is probably one of the most key elements that we need to acquire prior to putting on our gloves and entering a patient's mouth. There's a very old saying, don't ever treat a stranger. In reality, this is key as modern medicine is extending people's lives and allowing them to live with any number of medical complications successfully. This has a direct impact in the kind of dentistry that we are able to do. In addition to that, successful dentists know that one of the key elements to that success is relationship building. If you don't have a relationship with your patients, you don't have any kind of patient loyalty, and they will move based on price or insurance coverage. So to begin with, we need to improve communication skills. Many of us, just by nature, are somewhat introverted, and as a result, our comfort level for communication is lower. Once communication's been established, we need to work on our rapport, and we need to scaffold our specific questions with repeatable habits. Creating a scaffold or an algorithm helps that very organized, somewhat introverted personality to go through a routine in order to establish consistent rapport between themselves and patients. There's a real key to asking open-ended questions. Closed questions shut down communication, so we're going to practice that open-ended question. And then there's utilization of our clinical skills and clinical reasoning. It's important that we have the ability to extrapolate the information that's being provided with the patient into a medical model and have a sense of what maybe they're not saying either because they don't understand or they're uncomfortable. And then we need to have measurable success in our interviewing skill set. Again, we never treat strangers, so our ability to communicate and to draw that patient out to get that information is pretty much key in our continued development as practitioners. So, before you sit down and talk to your patient, you should have an idea of what you're trying to accomplish. Ideally, having a script or having a loose idea of point A to B, C is kind of critical. And you need to be very careful about your tone. Tone, especially when it feels condescending, is really going to be a pretty active red flag for most patients. So practicing a respectful tone is very important. Next step is, what's your goal for this communication? Are we trying to determine why this emergency patient has dropped into your schedule, or why this particular patient is continuing to have pain on this filling? So what's the goal point here? Then how do we use good judgment in regard to timing those questions or inquiries? For the most part, there's nothing more frustrating than having somebody interrupt you in the middle of a thought. And as dentists, we have a tendency to just want to get to the point. What is it that I can fix for you? So it's important that we time how we question, that we let somebody kind of get their whole thought out, so that we make sure, again, that we're implying that respectful tone. It's important to make eye contact. I cannot tell you how often I see people interact with their patients while they're looking at the computer or looking down at a piece of paper. You can't do that. You've got to make eye contact. You've got to pause, and you've got to have open body language to emphasize your thoughts and to, again, emphasize that desire for communication and rapport. If you are back to the patient, head down, mask and eyeglasses and the whole bit on, you are very clearly telling them that they are not the important person and the important action in the room. So we really need to break that down. Additionally, even though you might love your dental assistants, you might love your best friends, It's very important that you give undivided attention to the patient and to the caregiver. You can't be taking phone calls. You can't be listening to an internal mic telling you, "Doc, we got this other patient ready to go." You've got to appear that your attention is completely devoted to that patient at that time. You need to learn to be a good listener. It's fine to hear what somebody says, but to actually listen means that you engage enough to understand the underlying context and that you engage enough to actually respond in a way that emphasizes what it is that the patient is looking for. It's important to be reflective and active. And what that means as a listener is that you need to take a piece of what they've communicated and reflect it back to them. So for example, if they say, "Doc, I'm scared of needles," it's important to say something along the lines of, "What I'm hearing you say is that you're really concerned about the part where I get you numb, and the pain that might be associated with that. And let's figure out a way to diminish that stress." And then ideally what they're going to say back to you is something along the lines of, "Yeah, that's exactly what I mean." When they say to you, "No, that's not what I said," that's when you need to, again, clip out what you heard and reflect it back along with a, "This is what I think you want from me." That communication effort shows the patient that you are engaged with them as a human, not just the root canal and chair number 3. You need to be smart about scheduling follow-ups. A lot of the time with certain patients, their ability to absorb what you're saying is really limited, and you need to be able to literally create another follow-up, whether that's immediately after you finish with the office manager or with the front desk lady, or you actually have to make another consult appointment with them. It's critical that you understand that this is what this patient needs. And again, I cannot say it enough, cutting off the patient in the midst of a thought is just such a large red flag and will immediately eliminate that patient's willingness to be part of the team. So you need to pause. You need to take a second, get your thought out, and let them get their thought out. Let them ask questions, let them raise their concerns. You don't really know what their concerns are in specific, so you have to give them that respect. So one of the things that should happen when you're doing your initial assessment is gather a snapshot of the scene. So if you are entering a closed room, is that patient sitting in a chair that's not the dental chair? Has that patient got their purse on their lap, or are they looking out the window? Are they tapping their foot? Are they giving you eye expression or facial language that's telling you that they're pissed at you? Are they sweating? Are they exhibiting high color in their face? All of this gives you information about the stress level of the situation. Once you've got that, we need to perform a primary assessment. This is basically an initial inquisition about, do you need any pre-medication? Do you have any allergies? Have you had any negative experiences with the dentist? A quick set of questions that basically tells you, okay, I'm going to need to kick into this level of communication in order to work with this patient. Once the primary assessment's been performed, there needs to be medical history. I cannot emphasize enough, medical history changes on a dime. Regardless of your patient's age, every 6 months minimum, you need to inquire as to whether or not there's been any change in the modification of the patient's health and or medications and or living situation. That verification is critical because things do change. You can take a perfectly healthy person in January and we see them again in July, they may have had a heart attack. They may have been diagnosed with cancer. You don't know, so you need to update that history. Then we're going to perform a secondary assessment. This is going to get us more in-depth into certain areas. And then finally, a reassessment prior to presenting the plan. Okay, so let's talk about an assessment. I kind of love the picture to the right because it's always fascinating to me what people think a dentist is versus, of course, what we think a dentist is. So when you're performing the assessment, there should be a series of steps. And basically, just going over this, we need to know the action plan. We need to know the systemic diseases that the patient has. We need to know if there were previous hospitalizations and or previous surgeries and how long ago that was. If you get information that tells you it was a complex surgery or complex hospitalization, it's helpful to know what the continuing care is, how long the time in the hospital was, and how complicated it was. Previous anesthesia events give you an idea of how their airway copes with stressors like full general anesthesia. So that's another question we want to ask. Again, medications and allergies are just kind of a basic. We always need that information. Gently probing into family history and social history is kind of critical. Again, we need to know what patient supports exist, what the living situation is, what the picture is for this patient's health. Drug and tobacco use are especially critical for our treatment plan. So again, we need to probe with respect into that area. And then we need a dental history. We need to know how those dental treatments went from the patient's point of view, how successful they perceive their work is, how often they've been to the dentist. If the last time they were at the dentist was 10 years ago and the dentist stabbed them through the cheek, all of that is the hole you have to crawl out of as you build rapport with this patient. So again, dental history is critical. And this is all gathering information from the patient. It's allowing you to get to know them. It's also allowing you to understand what their dental IQ, their medical IQ is, because again, that's going to help you to choose the right terminology to utilize to develop that rapport and to explain what needs to happen. So how do we establish rapport? And it's always interesting to me when you walk into a preschool or a kindergarten, children just kind of gravitate towards each other and they begin to make friends very, very quickly and easily. The older we get, the more complex it is to actually develop a relationship. And we seem to forget every 10 years how to do basics like be courteous, establish communication, check in with the person you're talking to that they're understanding what you say and they feel heard. So we're going to go over how to build a rapport. You need to demonstrate empathy. You need to put your hand on their shoulder and say, I hear you, you're in pain, I'm sorry, let's see what we can do for you. I hear you had to wait an hour last time, let's see if we can move this along faster. You need to establish that you actually care, that you see them as a person. You need to minimize the distractions and interruptions that are around you when you're having a conversation. If you're in the midst of the open bay in the team setting, you need to get closer to your patient so that they definitely have a sense that you're listening. You don't need to turn the patient light on or your loop light on instantly, so that again, you're creating more of an intimacy so the patient feels heard. Again, with the active listening and the nonverbals. Take a second and examine how you stand or sit. Do you cross your legs? Do you cross your arms? Do you put your hands in front of your personal space? Do you cross your hands over your chest? The key to expressing an open, active position is to lean forward, maintain eye contact, nod appropriately, put your arms to your sides or resting on your thighs if you're sitting. Basically create that open environment, that engaged environment. And make a point of not necessarily being higher than your patient. So if you've seated your patient, sit down, get at the same eye level. You want to offer feedback. You want to literally make sure that you're checking in. Did I miss anything? Did I fail to understand what you're saying? This is what I heard. Ask them about their general life. I once went for a colonoscopy when I was very, very young, and that's a very intimate and invasive procedure. And I was very anxious. And the first thing that the doc said is, "Oh, I see that you're in dental school. I have a little pain right here in my tooth. What do you think? At that time, it made me feel more at ease. And it was thoughtful. I knew he had read who I was. He'd read what I did for a living. And it made it easier to let go of my stress. Um, you want to check in with, how do you feel about doing this? How do you feel about doing that? What in the situation or issue is troubling you? How are you handling that at home? How would you like to handle that? That must be difficult for you. All of these kind of base phrases allow you to develop that rapport. Um, Another kind of key is the BATHE acronym. Um, we want to look at the background of our conversation, the affect that we're displaying, the trouble that we're addressing, how we're handling the situation, and how we're emphasizing empathy. It's important to understand that all of us function with bias, and identifying your bias helps you to be a more open and objective physician. So, having a little bit of deep diving into your own personality to understand those biases can help you um, be a better physician. These days, regardless of your patient population, you need to ask about alternative medications. For example, is your patient eschewing toothbrushing in favor of oil pulling? Are they utilizing charcoal materials? Do they go to their Ayurvedic doctor and balance their chakras prior to a dental appointment? Um, Whether or not you're comfortable with these alternatives, they've become a part of our society, and we do need to have an understanding of them, an understanding of what science is available concerning them, and an understanding of how we're going to manage that with the patient. You're not going to dissuade the patient by telling them that that's hogwash or worthless. You're going to dissuade or direct or guide the patient in a another way based on your demonstration of empathy and your understanding of the materials. We want to talk about lifestyle changes. As our patients get older, they may be post a diabetes diagnosis or post a heart attack or post a stroke. We need to bend with their new lifestyle in order to better care for their mouths. When we get a negative response or resistant to change, we need to be open to how we're going to address it. So, trying to get somebody to lose weight, or trying to get somebody to floss, or trying to get somebody to stop smoking. Those are complex issues, and those are major coping skills for that person. We need to tread lightly, and we need to understand how we can bring them into a pathway where they are willing to even consider a change. Um, a tool for doing that can often be that we're highlighting the effect. So, a popular tool for getting diabetics to consider losing weight is if they have grandchildren. Do you want to be active with them? Do you want to see them graduate from high school? Do you want to see them get married? How you take care of yourself is going to have a direct impact in the opportunities that you have. Um, when you run into that resistance and that negativity, that's your opportunity to really lean into the questioning. Ask the patient, what is it they think is the most difficult aspect? What is it that they think is going to trip them up? Um, Ask them if they've seen someone else with success and how that success seems to have happened in their point of view. Um, what that does is it gives you an idea of how they perceive others' success, how they perceive their own abilities, and it also uncovers the quote unquote elephant in the room. If the patient says, well, I don't want to give up smoking, I like the taste, or I don't want to give up smoking, it's my security blanket, that's where you got to drill down and actually make a connection and start talking about how we can be positive in a change. So the easiest way to scaffold a session or a structure is to have a pattern. You can operate that pattern from any different point of view. I've got 3 different standard kind of checklists that people utilize, but you need to develop one that works for you and feels comfortable and normal to you. Whether you decide to start with an introduction, hi, I'm Dr. So-and-so, and our goal today is to get an overall picture of your oral health and how that oral health needs to be maintained for your general health. So why are you here today? What's your chief complaint? What's the history of your current oral situation? What's your medical history? What's your systemic history, family history, drug history, social history? When we're training a medical student, that entire gathering of information can represent about an hour to an hour and 20 minutes. Generally speaking, as dentists, we don't spend that much time, but when you're first learning the skill of gathering that information, it should be, again, a repeatable pattern. You've memorized the quote unquote 8 to 10 steps that your structure has, and you're getting a feel for how long it takes you to acquire that information. Ultimately, there's tons of open source opportunities with health histories, but it's helpful to create a personal form that works for you. One of the things that's changed in my practice is we no longer assume that you're in a traditional nuclear family, that the person bringing the patient is the mom, the person living at home is the dad. We never make that assumption anymore. We have parent one, guardian one, parent two, guardian two. We frequently have a section asking, how does your child identify? These were just simply not tools that we had to utilize in the 90s or in the early 2000s, but they've become a part of our medical history as the society's changed. So let's talk about open-ended questions. What is an open-ended question? Basically, it's a question that can't be answered by yes or no. For example, we're going to just use a tool that a lot of parents use. You have a child who gets up in the morning and they don't want to put on shoes. They want to go to school barefoot, or they want to just stay barefoot, or they want to stay in their footy jammies. Rather than say, hey, do you want to put on shoes today? Which, no, I don't. Thank you. You ask them, would you like to wear your red sneakers or your blue sneakers? Would you like to wear your ballet slippers or your snorkel fins? Again, this is not a question that can simply be answered yes or no. The patient, the child, the person you're communicating with kind of has to give you their feedback and their answer in their own words. So to the left, I've got the open-ended do's and don'ts. Do ask what, why, and how, but stay away from broad and lengthy conversation points. It's important to bring your question, your point, to a short and sweet conclusion so that the person doesn't get lost in the woods or the weeds. Don't give them prompts. So I think you know that flossing is great. How's your flossing going at home? Don't force an answer, and don't interrupt while they're answering. Again, it's critical to let them finish their thought. So how are we going to utilize our clinical skill and our clinical judgment? This is where all those years of school starts to play into what appears to be a casual conversation. We go ahead and we get the need of the patient. Then we evaluate whether that need is in point of fact an existing need, and we begin to make a clinical plan, right? We hear from them, well, I have pain up on the upper left. We think, well, could be perio, could be endo, could be a simple filling, could be a disease process. We start to create a spreadsheet, if you will, of the possible opportunities. Then we get the next piece of information. Maybe it's, this is a sharp shooting pain, this is a spontaneous pain, this is a pain that comes whether I'm eating or not, this is a pain that lingers. Again, every little bit of cue or fact that the patient drops on you gives you that ability to sort of analyze the situation and start to eliminate the excess diagnosis and zero in on the actual ideal plan. You need to practice this. No matter what you think, you could be a phenomenal talker. There are plenty of phenomenal talkers out there. But do you actually know how to elicit the information? Do you understand what the feedback and the reflection is in order to really start to eliminate the unnecessary diagnostics? How you do that is going to develop a coalition between you and the patient. They're more likely to accept treatment, they're more likely to make lifestyle changes, which is ultimately going to result in a more pleasant experience for both you and them. So, a measurable success in your interviewing skill set is how did you get the information forward to the patient? How did you acquire the information from the patient? So in 3 areas: patient education, infection control, and documentation. There's an evaluation very similar to the rubrics that we answer for, did you do a good prep? Did you do a good temporary? Have you created in the patient education the opportunity, the correct home care plan, which is specific to that patient and is presented in a way the patient can take, i.e., are they hard of hearing and you opted for an oral presentation with no written follow-up? This is clearly not going to provide the best absorption of the plan. You presented the plan, but you didn't get any feedback from the patient. Again, this is going to cause you a problem. So we need to make sure that in any area, again, I've given you 3 examples, but go ahead and take financials and work through how you can determine what's excellent, what needs improvement, and what's a critical error. All of this, again, is skill practice for the purpose of having retained patients and successful treatment plan. Okay, so the ISTE Standard 4 model is promotion of digital citizenship and responsibility and addressing diverse needs of learners through a learner-centered strategy. Basically, again, this is your rubric showing how we're beginning to utilize tools and develop success. When we're looking at a grading criteria, like how successful are you, something like this can be applied. We look at what strategies you put into place. How successful were you with the tools that were available to you, and how successful are you at getting that patient to buy in? In many ways, the patients that we have at the dental school can be incredibly cooperative and incredibly supportive, and they can also be incredibly flaky. The most successful students are the people that recognize what it was that brought that patient back in. They really tap into the drives and needs of that patient, and they make the patient part of the team. Okay, I cannot emphasize enough that if you didn't write it down from the point of view of others, it didn't happen. When we look at our credibility against that of the patient, we certainly have credibility in our knowledge base, but we lose credibility in that the patient has one interaction with us. We have 40 interactions in a day with different patients. That patient goes to the dentist 2 or 4 or 8 times a year. We are performing dentistry, again, 30, 40 times a day times 5 days a week. So our documentation really becomes critical. We need to have, again, an organized scaffold. For example, this is the description of why the patient's here. This is the diagnosis and treatment plan. This is what we actually did and whether or not there was an adverse outcome or a complication, and then list how we inform the patient of this. If we detach a file, It's not necessarily a deal breaker, but it better be in the notes because the file is going to be visible to others who take an x-ray. We need to have accurate patient personal information, accurate medical history, regular updates. We need to always do an oral cancer screening and a TMJ evaluation. Again, TMJs start to go south without a lot of warning. Oral cancers, this is our responsibility as the oral physician to be checking every patient. This means you have to pull the tongue out. You have to tilt the tongue left and right. You have to manipulate the head of the patient so that you're lifting that jawline and you're getting a visual of the pharynx, a visual of the soft palate, the hard palate. You need to pull those cheeks back. You need to flip the lip. All of these are just a part of your exam. And then you actually have to write down what you saw. It's not enough for you to notice the white plaque that was on the right-hand side only. You have to have it in your notes, and you need to have descriptors. Those descriptors are standard across the board. It's not okay to say there's a funky white lesion on the left side. You need to be descriptive. We need to have the ability to generate reports for others that are participating in this process, whether it's the primary care physician or the cardiologist or the neurologist or Aunt Sue who's paying for the work or grandma who's paying for the work. So you need to have your notes in a structure where you can create a short consultation report, a short stakeholder report. And then finally, you need to be very careful that your notes don't reflect a bias. I had an RDA who had a tendency to quite literally write in the notes, patient went batshit. This is not a medical description. You cannot also say the patient was dirty, the patient used bad language, whatever it is. You need to be very careful with your notes that you're not basically saying those people or that should be expected because of this. You have to be aware of bias and sensitive. So at minimum, your note has to have exam, it has to have treatment notes, it has to have follow-up, it has to have a record of canceled or missed appointments. You need to have a separate, specific written informed consent that says that all questions were asked and answered. Risks, benefits, and alternatives and prognosis for each choice were reviewed and understood, and that has to be signed ideally by both you and the patient. It is wise to collect models or photographs of the information of that patient, radiographs at intervals that are indicated by the ADA or by the specialty board, or if you're going off of the recommended, why you're going off of it. For example, we regularly take bite wings twice a year, occlusals once a year, full mouth x-rays once every 5 years, Panorex once every 5 years, whatever it is that is your pattern. However, patient presents today having gotten a hockey puck to the lower right jaw while at the Stanley Cup finals and appears to have fractured teeth. So we're going to opt for the following x-rays for that reason. Do keep in mind what is in the patient's financials or in the general notes are not necessarily access to the patient, whereas every note that you put in that's a clinical note is absolutely owned by both you and the patient. So always think in terms of having to read out loud anything that you write down. You need to have contact notes. I know contact notes are a real pain right now in school, but we need to know that the patient called in and talked to the front desk, or that the patient called in and talked to an RDA. You're ultimately responsible for each and every interaction, and if you have no notes, it didn't happen as far as anybody else is concerned. There are tools for you to indicate a frustrating patient or a problem patient, if you will. It's really a bad idea to label the chart problem patient. Obviously, again, the chart is jointly owned by patient and doc, and you don't want to set yourself up for a bad situation. Back in the day when there were paper charts, a lot of docs used a color code system. So a black sticker might be somebody that defaulted on payments previously. A red sticker might be something that indicates the patient is difficult to deal with emotionally. We don't have color coding anymore, but we have pop-up notes. You can place a statement in that pop-up note that is innocuous. It doesn't have to be something that's going to be, this is a bad patient, or this is a bad financial risk. It can be a simple phrase that you select that gives everybody in the office sort of the inside knowledge that, okay, this is somebody we have to handle a certain way, or this is somebody that we need to collect from up front, or whatever. In my office, what we had was a verbal conversation. So if you saw somebody that appeared to be in trouble, you might walk up to them and ask them if they had a red pen. So sorry to disturb you. Do you happen to have a red pen? And if the answer is no, then that's your clue as this person coming in to step in and help with the situation. If the answer is, oh yeah, I do, thanks, then no, they're handling it, they're okay. So very rarely did the red pen conversation indicate that the patient was aware that we were communicating, help, I need help, or whatever. Another way that my staff let me know that I was running behind is they would take out fresh gloves and set them next to me. That was the signal that, hey, you've got a lot of patients backed up, you need to wrap it up, doc. So again, you can develop an innocuous set of alternative conversation points to allow your staff to communicate more effectively with you, and you to communicate more effectively with them. Do recognize that one of the things that a patient can do, since our records are co-owned, is that the patient who signs the consent can add an amendment to the record, 250 words per incident. So let's say that you tell them, I reviewed risk, benefits, and alternatives and prognosis for this treatment. We then proceeded to do the treatment and the patient swallowed the tooth. The patient can say, I disagree with the doctor. They didn't tell me what the risks were. They didn't tell me I had to hold still. They didn't use anything to protect my throat. All of those things then become part of the record. And that is a perfectly legitimate thing that they can do. So be aware that, again, this is a co-owned chart, and the patient has the right, if they are the one who consented, to write a 250 word per incident amendment to your record. It's critical that you never alter a record. There's huge temptation when there is a second eye to go back over and thicken up your notes, if you will, or add more bulk there. Don't do it. Don't cross out dates. Don't erase typed verbiage. If you feel the need to add to a record, put the date in that you're adding and add as an addendum, I am adding this note. You can amend a record with date, time, and reason for the amendment, but never alter or remove the original commentary. This is a big point and something that needs to sit in your brain for a second. Ideally, finish the note directly after finishing with the patient. If you don't have time to do that, you really should not leave the building per night without addressing each and every one of your records. If you're on computer, those digital timers reflect when you actually sat down to write the note. So if a lawyer were to subpoena it, it won't just say September 15th, 2004. It'll say September 15th, 2004. The patient was checked in at 9 a.m. The note was written at 9 p.m. Again, this can impact your credibility. So it's also important that if your patient wants you to do something that you don't agree with and you still decide to do it, you need to document that as AMA, against medical advice, or you need to make a choice to not perform. Patient's consent is permeable. And when I say it's permeable, there are situations where the law says, I don't care that you as the doctor gave them the information. They as the patient simply aren't able to understand it. They don't have the training. It was your job as the professional to protect them. So, for example, the patient comes in complaining of intimate relationships being blocked because their teeth are sharp and they want you to file down their teeth. You know, filing down their teeth is simply unacceptable. If you opt to do it because the patient has made that choice, and then the patient ends up losing those teeth or having root canals or needing the cost of implants, you may be stuck with that charge and that censor from the board because you know better. And just because the patient wanted it wasn't adequate. More importantly or more regularly, it's the decision to take x-rays. And the patient says, well, I don't want to pay for that, or I don't think it's necessary. That repeated missing of x-rays is your responsibility. And you are obligated to dismiss that patient from your practice if they are not adhering to your requirements, because that's your license and you're the expert. You cannot force somebody to do something, but you absolutely can dismiss them from your practice if they are a danger to themselves or if you are being put in a less than ideal situation as the practitioner. We're going to move on to therapeutic management of common oral lesions. So looking down at the left-hand side, we're looking at aphthous ulcers, canker sores. When we're dealing with recurrent aphthous stomatitis, there really isn't a clear etiology. Some people say it's too much sunlight. Some people say it's not enough sunlight. Some people say it's food. Some people say it's stress. Some argue that it's piggybacking on an overall systemic weakness or an immunocompromised situation. Bottom line is, we don't know exactly why aphthous ulcers occur, and we don't have a definitive treatment for them. We can suggest Orabase or Oragel. That's like putting a flexible Band-Aid over it. Generally speaking, the standard course for aphthous stomatitis is 7 to 14 days from onset of the ulceration, 14 to 21 days from onset of the prodromal stage to post-end. We can use Dibacterol. That's a chemical way to basically close over the lesion and encourage quicker healing. We can do laser treatment on it. We can provide palliative care or diet modification. For example, avoid salty, sharp, spicy, carbonated, sour, and acidic foods. We can provide a systemic steroid or a topical steroid. Down below on the right-hand side, I have provided you with a standard dexamethasone elixir diagnosis or treatment. Prescription. Please take a look at the steroid prescription. Again, it's fair to say that you can look up the actual verbiage of the prescription. So in an exam, I am unlikely to ask you to write down the exact dexamethasone prescription, but I am likely to ask you, what are my options in a severe case of aphthous? Left-hand side is herpetic infections. Now, it's the right upper picture that's showing you a herpetic lesion, but it's the left area that shows the diagnosis situation. The most common option for herpetic infections is topical antivirals or palliative care. We don't generally prescribe a systemic antiviral because most antivirals themselves will cause more stress and effort to the system than just letting the virus run its course. Our topical antiviral of choice is a magic mouthwash. It's made up of diphenhydramine and or hydrocortisone and nystatin, and sometimes an antibiotic mixed with viscous lidocaine, which is the way in which to numb the lesion. Magic mouthwash does come in multiple combinations. But generally speaking, it will include lidocaine for the numbing value. It will include an anti-inflammatory of some kind, specifically targeting the IgG, IgA cascades, and it will frequently carry some element to either settle the stomach, like a Mycolog or a Tums type version, or it will carry prophylactic antibiotics or prophylactic antifungals. Generally speaking, the mix is 3 parts or 5 parts equally divided, and that will be put into a single bottle that can be shook up to mix everything together. And then the recommendation is to swish basically a teaspoon in the mouth, hold it in the mouth for as long as is tolerable to the patient, then spit everything out. And then depending on, again, the supplemental things that are in it, the antifungal, the antibiotic, no more than 4 times, no more than 6 times a day, no more than 4 hours. So when I say no more than 4 hours, I mean you need to wait 4 hours. As people remove things like the antifungal and the antibiotic, you can sometimes use it more often. But that 4-hour mark is pretty consistent. Okay, so let's talk about candidiasis and xerostomia. Fungal infections in the mouth are generally present more in immunocompromised patients than in your quote-unquote normal healthy patients. So the presence of candidiasis does give you insight into the fact that you probably need to ask some more questions about the health situation. In my particular aspect of our field, we used to place a fair number of flippers. We still do, secondary to trauma. Those patients frequently do not wish to remove their flipper in public. So we would get a lot of candidiasis at the end of the summer because those kids would have gone to camp and they wouldn't have removed their appliance the entire time they were in camp. The treatment for candidiasis is nystatin oral suspension, but it's important to be aware of the fact that if this is secondary to an appliance, you need to treat the appliance as well, and that's treated by nystatin ointment. Clotrimazole is also a popular choice. If you're going to use clotrimazole, it doesn't generally come in an oral suspension, it comes in a troche. A troche is like a lozenge, and you're going to go ahead and dissolve that up against your tongue or your cheek 5 or 6 times a day. As far as having knowledge of what the prescription is going to be, you should have a plan for looking it up. But again, I am mostly interested in if the patient presents with thrush or if the patient presents with an appliance where fungus is growing, what is your plan? How are you going to handle it? In many populations today where we're dealing with polypharmacy, xerostomia is becoming a bigger and bigger issue. So we need to talk about how we're going to generate artificial saliva. Xerostomia is going to end up causing a lot of secondary oral health complications. So there's any of a number of products that are over-the-counter products that can help. There's sodium carboxymethyl cellulose, there's Xerolube, there's Orex, there's Salivart, there's Biotene, and there's glycerin. Any of those products can generate an artificial wet environment, and they should definitely be investigated. You can recommend a salivary stimulant like pilocarpine hydrochloride, but do be aware that that prescription, although perfectly appropriate within our realm of experience, is not one generally written by dentists. So you may run into the pharmacist being concerned as to why you've opted for pilocarpine. So you do need to be grounded well in the medical reasons behind that. Some of the immediate treatment options that you can apply to prevent decay would be stannous fluoride, sodium fluoride, or fluoride varnish. Believe it or not, fluoride varnish is a tool that we really shouldn't be letting go of once the patients turn 19. I I still regularly recommend to my special patients and many of my friends who do a more geriatric patient population are regularly using fluoride varnish as a way to protect the more vulnerable teeth. If they are going to be a gum or hard candy person, you really need to talk to them about sugar-free products. Again, there's nothing worse than having a dry mouth and then having them put a high sugar product up against that vulnerable tooth for hours on end. So again, sugar-free, xylitol, sweetened products are going to be your best friend. And then because xerostomia is a complication that that patient is suffering from, we really need to be doing an active fungal check every time they come in. Okay. Radiation and chemotherapy stomatitis. It's important for us to have a protocol for our patients that are experiencing radiation or chemotherapy. Unfortunately, these things cause some pretty significant mucositis and some pretty dramatic changes in the oral flora. As a result, these patients are very uncomfortable and frequently they drop weight very easily. They have difficulty sleeping. Their overall emotional state becomes weakened. We, as part of a larger healthcare team, need to have some tools in our tool belt to help that patient. Some of the options open, again, are Magic Mouthwash, diclonidine hydrochloride, lidocaine hydrochloride, antifungals, alkaline mouth rinses, artificial saliva, utilization of Toothets, MI paste, varnish, Biotene rinses, and Sensodyne. It's important, I think, to pre-plan how you're going to be part of that patient's chemo or radiation therapy. Managing the mouth is our area of expertise. It's a great opportunity for you to establish a collaborative relationship with the oncologist and also with the primary care physician. And it's frankly an area that we can demonstrate our knowledge as physicians. For example, as the platelet count starts to drop, as the A1C starts to give us issues, the introduction of Toothets, the introduction of neutralizing rinses demonstrates our understanding of the issues that the patient needs to deal with. 3 noticeable complications in radiation and chemo are burning tongue syndrome, taste disorders, and angular cheilitis. I would like you to be aware of the specific medications that we utilize to treat that. Burning tongue generally is Benadryl elixir. Taste disorders is zinc replacement. And angular cheilitis is Mycolog cream. Okay, toothbrush abrasion. We're seeing more and more toothbrush abrasion in all different ages of patients. We need to very quickly assess toothbrush abrasion, and a home care modification that can be done is transferring the grip. So instead of doing a full fist grip around your toothbrush, you make them hold on to the toothbrush with the thumb and the third finger. If you hold your toothbrush with those 2 digits, you're going to realize the grip is very light. That is one way to reduce the amount of force. You can switch them to an electric toothbrush or a sonic toothbrush, which doesn't require brushing force at all. They just move the brush physically, and the brush itself is generating the force. There is a 3-headed toothbrush that's very handy for home care on special patients and older patients. This toothbrush fits over the top and sides of the jaw, and you do a sweeping quadrant motion. Again, it's a lower pressure indication. We may very well have to address the damage that's been caused by abrasion, but we need to modify the home care in order to stop this problem, or we're literally having dissolving teeth that can't be salvaged over something where they're overdoing it. Avarix. This colored spot is not cancerous. This is basically a mole on the lip. We do not need to treat this, and we do not need to do anything more than monitor this. Moles can go from benign to something more interesting. So obviously having a photographic record and a measurement of this and then checking it annually is kind of our obligation again as the oral physician. Hairy tongue. Hairy tongue is a fun one. This is an abnormal coating on the dorsal surface of the tongue. It's relatively common, it's temporary, and it's largely harmless. It occurs as often as 13% of the population. I personally will never forget hairy tongue because when my third sister entered law school, she was having a lot of GI reflux and a lot of nerves, and she took a bunch of Pepto-Bismol the night before she started classes. And when she woke up in the morning, her tongue was pitch black and it had thick covering over it, and she was sure she'd woken up dying of some complication. So she called me and snapped a picture and sent it to me. And I was pleased to be able to tell her that it was the bismuth in the medication she'd taken the night before, and that all she had to do was basically brush it off and it wasn't coming back. This is it turned out to be a very nice thing for my sister, but it's also a nice thing to be able to diagnose this and help your patients. And it is relatively common. So again, the treatment there is removing the buildup from the tongue, flushing with water, and good oral hygiene. Okay, one of the biggest responsibilities that you have that distinguishes you as a physician and not a tooth jockey is an understanding of the medications that patients are on and the drug interactions that occur. Probably if you are communicating with upperclassmen, you are aware that this is a section where I do require pretty significant memorization. I want you to be aware of all the potential complications and interactions between antibiotics and antifungals, acetaminophen, aspirin and nonsteroidal anti-inflammatories, meperidine, propoxyphene, lidocaine, mepevacaine, barbiturates, benzodiazepines, and epinephrine or lordaephrin. Okay, so this slide specifically breaks down antimicrobials and antifungals and what they interact with, acetaminophen and what it interacts with, aspirin and nonsteroidals and what it interacts with, meperidine, propoxyphene, lidocaine, mepevacaine, barbiturates, benzos, and epi. So between these two slides, there's no way around it, people. You need to memorize it. I can promise you I will be asking for specifics, i.e. perhaps providing a list of these drugs and a list of these medications and asking you to match this between the two so that you demonstrate that, yes, I know this epinephrine is going to have an issue with beta blockers. Benzos are going to have an issue with oral contraceptives or digoxin. Acetaminophen is going to interact with alcohol and warfarin. Okay, specifically, this slide is also critical. It's the top 3 serious drug interactions that every dentist should know. Non-steroidal anti-inflammatories specifically inhibit renal excretion of lithium and lead to lithium toxicity. Metronidazole and fluconazole inhibit the metabolism of warfarin, blocking cytochrome P450, which causes an end result of dramatic increase in the patient's normalized ratios and potentially fatal bleeding complications. Propranolol and other non-selective beta adrenergic blocking agents inhibit vasodilatory effects of epinephrine, and this can lead to hypertensive reactions and concomitant reflex bradycardia. If you wish to look at this article in depth, the reference point is at the bottom, but these 3 interactions are also free game for the test. Okay. Gingival bleeding. You're going to see a great deal of gingival bleeding in patients over 50 in general, and especially females. Look for the following medications for contributing to this bleeding rate. There is the possible death complication associated with gingival bleeding. This can be related to vasoconstrictors and their interaction with tricyclic antidepressants, non-selective beta adrenergic blocking drugs, general anesthetics, and cocaine. Again, non-steroidal anti-inflammatories. You cannot utilize that with high-dose methotrexate, with anticoagulants, with lithium, and it is not indicated in patients with ulcerative colitis and Crohn's disease. It is also greatly discouraged in patients with irritable bowel syndrome. Aspirin should not be given with oral hypoglycemics, with valproic acid or carbonic anhydrase inhibitors. Diazepam and Xanax, grapefruit juice, triazolam, Tagamet, opioids, and Versed is contraindicated. Meperidine cannot be mixed with MAO inhibitors. And antibiotics with interactions for drugs include erythromycin, clarithromycin, metronidazole, rifampin, and doxycycline and monocycline. Again, you're going to see these same lists. And what I want you to be aware of is, okay, this patient is on metronidazole. We need to find out their social history. Are they drinking at all? Are they on any anticoagulants, anticonvulsants? Because this is going to have a direct impact. Okay. Alternative and complementary medicine is definitely taking more of a role. You're going to have people that come in telling you they handle pain through acupuncture. They're utilizing a chiropractor. They're modifying their diet. They're utilizing hypnosis. There are dental offices that utilize aromatherapy and heat relaxation or meditation tapes to help their patients tolerate the immediate stress of the diagnosis. There's any number of dentists who are also Reiki masters or who practice some kind of hypnotherapy for their patients. There are experts in office design that will tell you that painting your office in certain colors is going to encourage a healthier outcome for your patients. What I want you to be aware of in alternative medicine is whatever appropriate scientific resources you can bring to bear on this information, and also the understanding of mind-body medication. Many of these alternative medicines have been around for thousands and thousands of years and utilized by any number of cultures to great success. So just because our westernized medical philosophy doesn't really include legitimacy for these does not mean that we shouldn't acknowledge it. Also, there are a lot of alternative medications like St. John's wort that are being taken by our patients pretty regularly, and they can impact our dental experiences, maybe by increased bleeding, maybe by dry mouth. Our understanding and awareness is critical as our society delves more and more into this. So, some basic classifications of alternative medicine. There's mind-body interventions. This is examples like yoga, spirituality, and relaxation. Quite a bit of these mind-body interventions have been demonstrated both socially and scientifically to have significant impact on the health and well-being of our patients. Specifically, yoga has been tied to an increase in blood flow, to reducing the intermittent force associated with bruxism, to improve the alignment for both appointments and for the occlusal alignment. We see that our patients that have a strong faith in a higher power are frequently able to tolerate stress more effectively. And we see that utilizing visualization and doctor-directed stress management helps for the immediate success of a high stress, high stakes appointment. Some of the experts that you might see in manipulative body-based therapies are massage therapists, physical therapists, chiropractors, and osteopathy practitioners. It is a personal decision whether or not you investigate these methods, but there is solid scientific proof that these are options that do help your patient in the outcome. So alternative medical systems, these are actually naturopath type doctors that are approaching a dental situation or a holistic holistic body situation from a different point of view than Western medicine. So homeopathy is present quite a bit. This can be utilization of different herbs and even possibly different toxic medications at a very, very low dose to help with a variety of different medical systems. Those of you that have children may have used Highland teething tablets. That is a homeopathy treatment. Naturopathy is a holistic approach to dentistry integrating mouth with whole body. Again, the naturopathy people that we deal with are frequently going to talk about the toxicity of the materials that we use, and they're going to have a list of materials that they find don't interfere with holistic body meridians. And when I say meridians in that tone, I don't mean to imply that I do not respect naturopathy. There is definitely room in everybody's practice for this element. It is something that I utilize with a little bit less frequency than some of the other techniques. Ayurvedic medicine is a long-standing and well-recognized division of Eastern-based medication. You'll see management of a variety of different systemic issues like systemic inflammation through the following list of products that they're recommending to their patients. Okay, energy therapy is again another classification of alternative medicine. This can be Reiki work, this can be Qigong, which by the way has been documented consistently by both American and European researchers as having an increase in salivary flow, which can be critical for our older patients, and Qigong is something that can be performed regularly by a more immunocompromised, a more body weakened, or older patient. So it can be a very helpful thing. And then magnets are another source of energy transference that people have shown to have some success in oral medicine. So here are a list of any number of holistic medications that our patients are frequently utilizing as ways to deal with issues. Again, I am unlikely to test specifically for each and every one of these, i.e. I don't think you need to memorize it. I do want you to be aware of some of the options. For example, belladonna is a recognized toxic plant, but we've used it for years in a different dosage for dealing with cardiac issues, and it's been linked to helping ease toothache, early abscess, and bruxism, as well as preventing dry socket post-extraction. You take a look at actonite. again, recognized significant poison. But in homeopathy, used in extraordinarily small doses, we're seeing a reduction in panic, fright, general mental and physical restlessness, and the dropping of trigeminal neuralgia. So I think it's most important to be aware of the fact that there is room within a westernized medical practice to have some of these tools. Also, if your patient is choosing to use one of these medications or one of these concentrations, you need to know what the potential impact is for the oral cavity. Okay, folks, that is the end of this lecture. Please be aware, since this is a recorded lecture, that there will be a quiz the following week, just to make sure you've had a chance to listen to it. You have a lovely 3-day weekend, and I will see you next Wednesday. Take care.